All right. In this lecture, we're going to go over a very, very high yield topic for USMLE step one, step two, and probably for the rest of your life, and that's going to be multiple myeloma. So really just a few objectives. We're going to discuss the presentation, pathophys, diagnostic approach, and the management of multiple myeloma, and then we'll do a putting it all together question. So here's a case for us to consider to kind of prime us. We have a 75-year-old man presents to your clinic with complaints of mild confusion, constipation, increased urination, and fatigue. CBC is notable for a hemoglobin of 11 and MCV of 87. CMP demonstrates a calcium of 12.1, BUN of 32, and a creatinine of 1.5. His baseline is 1.1. Which of the following may also be present in this patient? May we likely see macroglacia, bone lytic lesions on X-ray, elevated albumin levels, or elevated parathyroid hormone? So take a second, pause, and consider. So when I read this question, right, first, like, look at who is your patient, right? 75-year-old man. So that already puts me into like a category of kind of what I'm thinking about when I look at this whole picture. We see they have complaints of mild confusion, constipation, increased urination, and fatigue. Immediately, when I think of those, without even looking at the labs, I'm already keying in on hypercalcemia, right? If you remember, there's like that mnemonic stones, bones, groans, and psychiatric overtones, which are classic symptoms of hypercalcemia. Um, so elevated calcium levels can cause depression. It can cause confusion. It can mess with your GI tract and peristalsis and lead to constipation. It can deposit into the kidney and can cause kidney stones. It can cause increased urination. It can cause increased thirst, and then overall fatigue, right? So that's kind of leading there. And then we also see the hemoglobin's 11, right? So which is low, which may also be contributing to the patient's fatigue. Because remember, when you have anemia, we have low levels of hemoglobin, so there's less oxygen transport to our tissues, which can lead to an overall state of fatigue. Remember, these patients may also have dyspnea. I've talked about this before, but whenever you see a patient with new onset dyspnea, we always want to have anemia in our differential, right? Because if there's less oxygen transportation to the tissues, it can lead to a sense of breathlessness, right? Dyspnea. Um, and then we see our MCV is 87. So this is a really important concept for all my new M1s who are starting their hem-onc unit soon or very soon, depending on when you're going to watch this. But I can differentiate my anemia framework based on the MCV, right? And I have a lecture on anemia, and I might redo it too, and add more to it. But there's a lecture on my YouTube channel on anemia. But when I think about an MCV of 87, I think about my normocytic anemia. And remember, we can break it down into reticulocyte increased production, so hyperproliferative, or low reticulocyte production, so hypoproliferative. Um, in this case, we don't need to go down that route to really answer this question, but we could consider it down the line. And then we see, okay, yeah, my calcium is actually elevated. And then we have an elevated BUN to creatinine ratio, right? And both the BUN and creatinine are elevated, which tells me there's some sort of renal insufficiency. So when I take a look at this, right, we have hypercalcemia, we have renal insufficiency, we have anemia. And what's that last piece I'm missing, right? If we're thinking about our classic crab symptoms, right? So all of this, we have an older gentleman with hypercalcemia, renal insufficiency, and anemia, right? I'm really trying to key you in on a diagnosis of MGUS or multiple myeloma or some sort of plasma cell dyscrasia is where this question is leading me to. So that last, right, the crab mnemonic, which we're going to talk about very soon here, that B in the crab mnemonic stands for bone lytic lesions and back pain. Okay. So the best answer for this question would be bone lytic lesions. Okay. I will tell you, and we'll talk about the mechanism behind those bone lytic lesions. I will tell you macroglacia is kind of a tricky question or like an answer option here because sometimes, rarely, patients with multiple myeloma can have macroglacia, and that's secondary to AL amyloidosis, which is also secondary to multiple myeloma. So you have multiple myeloma, which is a chronic inflammatory disease, which can lead to the increased production of AL amyloid. And the increased production of AL amyloid can deposit into the tongue, which causes macroglacia. Now, the thing though is that's like a secondary process of multiple myeloma, whereas bone lytic lesions is occurring due to the myeloma process itself, right? And we'll talk about the mechanism why it's not super important now. I want to touch on that later because that's actually my putting it all together question. So I don't want to like spoil the surprise there. Um, but so you should always consider like macroglacia with amyloidosis, B12 deficiency, iron deficiency can cause it as well. It's not the best answer here when I have bone lytic lesions as an option, right? So osteoclast activity, right, leading to the production of bone lytic lesions in the spine. And again, I'm going to really, really dive deep into this in a second, or like when we get to the end of the lecture. You can read my brief explanation here, but I'll go into even further. And then elevated albumin levels. When I think about a chronic inflammatory process, albumin is what we call a negative phase reactant. So when we have an inflammatory process going on, we have the liver switches from making albumin to making a lot of the acute phase reactants, things like ferritin, fibrinogen. We make more thrombopoietin, so we make more platelets. We get reactive thrombocytosis, right? We're not going to have elevated albumin. And in fact, albumin is often low or normal. Also, because the hypercalcemia can distort my albumin measurements. But really, in general, the albumin level is either normal or low. And we're going to talk about why that's really important for calculating what's called a gamma globulin gap in a little bit. And then we think about elevated parathyroid hormone. So whenever I see a patient with hypercalcemia, the first thing I need to do is decide, hey, is this parathyroid hormone dependent or independent? So one of the first tests we always run for a patient who has hypercalcemia is we'll get a parathyroid hormone, right? We'll get parathyroid hormone and vitamin D are usually two of the first ones. We can also get an iCal, an ionized calcium, which tells me the free level of calcium, because the serum calcium we get, that is not the free actively the metabolically active form of calcium. The serum calcium we get on the CMP is the bound calcium. And so sometimes we just like to see, okay, what is the actual ionized calcium that's metabolically active? Is it actually high? Is it actually low? Or is our serum calcium abnormal for another reason, such as a very, very common reason is a low calcium level, a low serum calcium level is often due to a low serum albumin. That's a story for another day. But really, what I need to do is when I see a patient that has elevated calcium levels, we're going to order a PTH and we're going to order a vitamin D. Now, in multiple myeloma, it's not a PTH-driven process. So we have 4 parathyroid glands sit right next to my thyroid. They secrete parathyroid hormone. Parathyroid hormone does a number of things. It goes down to the kidneys. It upregulates 1-alpha hydroxylase. So then any of the 25-OHD, the metabolically inactive storage form of vitamin D that's stuck in my liver, when it makes its way down to the proximal convoluted tubule, it runs across this enzyme. It gets converted into 1-alpha or 125-alpha hydroxylase. And that's my metabolically active form of vitamin D. That goes to the gut and it increases reabsorption of calcium. It's a steroid hormone, so it does it at the level of DNA regulation or gene transcription. Parathyroid hormone also goes to the osteoclasts and it upregulates them, and it allows us to chew up the bones, so we increase calcium and phosphate. And then parathyroid hormone goes to the kidney and it does a few other things. It increases the excretion of phosphate in the proximal convoluted tubule, and it increases the reabsorption of calcium in the distal convoluted tubule. All in all, parathyroid hormone increases calcium and decreases phosphate. However, in this case, right, the patient has increased calcium for a different mechanism, right? So in this case, calcium is going to be high and it's going to feed back and shut down the production of parathyroid hormone, right? This is our classic endocrine feedback pathway, right? There's CGRPs, calcium gated receptors, or CGRPs on my parathyroid glands that will bind to calcium. And when calcium is normal or high, the calcium binds and it shuts down the production of PTH. When calcium starts dipping a little bit, we lose that negative feedback and PTH gets released by those chief cells in the parathyroid hormone or the parathyroid glands. In this case, the elevated calcium is going to feed back and it's going to shut down the production of PTH. So if I have a patient with true multiple myeloma, I'm going to see an elevated calcium. We're going to get their PTH levels back, and their PTH levels should be low or undetectable. All right. So that's kind of breaking down this whole process, and we're going to kind of dive deeper into most of this. But the big things I want you to get out of this is being able to recognize common symptoms of multiple myeloma. So the crab mnemonic, our classic age, right? They're usually older men or women. Knowing that macroglacia can occur in multiple myeloma, but it's not super common. It's usually secondary to amyloidosis. Knowing that bone lytic lesions are classically what we see in multiple myeloma. It primarily impacts the spine, so the patients usually have back pain. Um, Again, we'll talk more about the mechanism soon. Knowing that albumin is a negative phase acute or negative phase reactant. So in times of inflammatory states, albumin actually ends up being low or normal instead of high because the liver is using all of its backbone products to make acute phase reactants instead of albumin. And then knowing that multiple myeloma is a PTH independent process to cause hypercalcemia. So again, we'll talk about the mechanism by which hypercalcemia occurs, but the elevated calcium occurs without the use of PTH. And so that elevated calcium feeds back and shuts down PTH. All right. So a little bit more about the pathophysiology of multiple myeloma. It's considered a malignant proliferation of my plasma cells. So remember, plasma cells are the differentiated form of B cells that secrete very specific antibodies to attack our pathogens, right? And so the thing is we take one type of plasma cell and we just replicate over and over and over and over and over again. And so they're all producing the same type of protein. Now, this is different from, let's say, your body gets infected with like streptococcal pneumonia, right? An encapsulated bacteria. Eventually, down the road, right, we have to go through the whole immunological process of innate and adaptive immunology, right? But eventually, we're going to make different B cells that can attack. They can make antibodies that can attack and opsonize that encapsulated bacteria to activate complement and do other kind of antibody-directed cytological destruction of these pathogens, right? So in this case, we may see different forms of antibodies. But in the cases of like multiple myeloma or plasma cell dyscrasias, the other really common one that we're going to talk about is Waldenstrom macroglobulinemia. In these cases, it's a malignant proliferation of the plasma cells. So we take one type of plasma cell and we just replicate it over and over and over again. So we're taking that same plasma cell that's secreting one type of antibody, and we've just made it a million times over again. So we're going to see a huge spike in that one type of antibody that it produces. So that's called a monoclonal immunoglobulin. We also call it an M protein, right? So that's like the shortened version of it. And instead of calling it a monoclonal immunoglobulin, we call it an M protein or an M spike. All right. So most commonly, this M protein is IgG or sometimes IgA, right? 20% will secrete only light chains. So you have to think back to your immunology, right? Our immunoglobulins are made up of light chains and heavy chains combined together. About 20% of the times, the multiple myeloma will only be a light chain monoclonal gammopathy. Well, they'll secrete either kappa or lambda, and these are what are called the Bence-Jones proteins. And the Bence-Jones proteins become a problem because those can get deposited into the kidney, and that can help lead to some of that renal insufficiency we cause, right? So the renal insufficiency can occur via multiple mechanisms of multiple myeloma. One of them is the Bence-Jones proteins, okay? So the monoclonal antibodies that are being produced over and over and over again, made up of these kappa and lambda chains, they can form these Bence-Jones proteins that then deposit into the kidney tubular system itself and cause damage. The elevated calcium can deposit into the tubular system and cause damage. Okay, if the patient with multiple myeloma develops amyloidosis, right? Amyloid is an acute phase reactant, right? If that amyloid gets to a high enough level, it too can deposit into the kidneys and cause damage, right? There's multiple mechanisms. So we don't want to just memorize, hey, they're going to have an elevated BUN and creatinine. We want to understand why, okay? We always want to understand the why. So this pathophysiology, the multiple myeloma arises from a post-germinal center B cell, right? The B cell that's already kind of progressed down the road. And then we know that IL-6 promotes myeloma growth, okay? It is the target of this beautiful drug we have called tocilizumab. Tocilizumab is an anti-IL-6 drug that is now being used in a lot of different rheumatological and some hematological processes. Okay, so we just talked all about the pathophysiology of multiple myeloma. Now let's talk about how we diagnose it, right? Your classic thing you're going to want to know for step 1 and step 2 are going to be this crab pneumonic and then what we need to see in the bone marrow. So I'm going to talk about the crab pneumonic first, and then we'll talk about the bone marrow. So we need one or more of the crab features or this SLIM biomarker. SLIM is very new. I want to say it's like 2024, 2025. It might even be a little bit earlier than that. Don't quote me on that. But SLIM is more of like a step three IM boards hematological fellowship question. I put it in here for completeness. What I want you to know for your board exam for step one and step two, probably even step three, are these crab mnemonics. So again, we've already saw it right in our intro slide, right? Our case to consider. A calcium, so the C in crab stands for calcium, above 11. The R stands for renal insufficiency. We have an elevated creatinine or GFR less than 40. I would throw elevated BUN on there as well. We have anemia, so a hemoglobin less than 10 or greater than 2 below normal. And then bone lesions, right? Again, they're lytic in nature. They're not sclerotic or osteoblastic. They're osteolytic, okay? Very important. So osteolytic for multiple myeloma. Um, so I need to see one or more of these. And again, it may not be a perfect world, right? Their calcium might be like 10.8. Their hemoglobin might be like 10.2. They might have like a creatinine like bumping up to like 1.8. Now, again, it's not meeting like full of the diagnosis, but that should like key you in on, hey, this patient might have a plasma cell dyscrasia or some sort of monoclonal gammopathy going on, and I need to do further workup. Okay. So what I do, right? The way we definitively diagnose is we do a bone marrow biopsy, right? There's a few steps we do in between that I'm going to talk about in a second. But to definitively diagnose multiple myeloma or any of these plasma cell dyscrasias, we need to do a bone marrow biopsy. So if you're reading a question, right, this is more of a step two concept rather than step one, because they don't really ask you much about like diagnostic processes for step one. But for step two, you want to know if they ask you what is the definitive way to diagnose this disorder, you want to say bone marrow biopsy. We're going to talk about something called an SPEP, UPEP with immunofixation. We've already talked about the crab mnemonic. Those are good to get us to that end goal where we say, hey, we've got enough data now that we need to do the biopsy to confirm. But the definitive diagnosis is if we see over 10% clonal plasma cells in the bone marrow, that is by definition, if they're IgG, then now we have multiple myeloma. And I've got a nice table that kind of summarizes that. And then just for your information, right, these SLIM biomarkers, if these are positive, the patient can have multiple myeloma even without the crab mnemonic. So this is where it gets a little tricky. But if we do a bone marrow biopsy and they have 60+% of clonal plasma cells in the marrow, that's enough to diagnose multiple myeloma, even if they don't have the crab mnemonic or the crab symptoms. If they have a light chain ratio of involved to uninvolved light chains over 100, we can diagnose multiple myeloma. If they have an MRI with more than one focal bone lesion, we can diagnose multiple myeloma. Again, for your tests, I want you to know the crabs, and I want you to know the greater than 10% clonal plasma cells in marrow or biopsy-proven plasmacytoma. Okay? That's what I want you to know. Again, these step one questions they're going to be asking you more about pathophysiology or what other symptoms would we expect to find. So kind of like the question I posed, I see that as more of a step one. Okay, we've got enough of these crab mnemonics. What else might we expect to see? For step two, they might be asking you what would be the next diagnostic step. And we'll talk about that in a second. All right, so key lab findings, right? This is now we're taking it a little bit further. When I look at my CMP, right? So whenever I suspect multiple myeloma, I need to get a CBC, usually with a differential, right? So we can look at my neutrophils, lymphocytes, eosinophils, basophils, and all my other kind of cell lines. I also want to get a CMP because I really am interested in looking at their total protein and their albumin, right? If I take their total protein and I subtract their albumin, if that value is greater than 4, that is what we call a positive gamma globulin gap, okay? With that, that tells me the patient has some sort of elevated amount of protein in their serum. Okay, so like normal protein is like the upper end, depending on which lab you're using, is like 8-ish, and the normal level of albumin is like 4-ish, but it really differs. So if I take the plasma protein or their serum protein on the CMP and I subtract their albumin, if that value is greater than 4, that's what we call, again, a positive gamma globulin gap. And that may key me in that there's some sort of abnormal protein in the patient's serum that is causing some sort of problem, right? So there's a step. I also always calculate the anion gap. And you're like, Adam, why the heck are you calculating an anion gap? Do you expect some sort of like anion gap metabolic acidosis? And no, the question is no, right? First, remind yourself, how do you calculate the anion gap? So that's going to be sodium minus, in parentheses, bicarb plus chloride. Right, normal is like 8 to 12-ish. Again, it really depends on your lab assay, but I usually consider 8 to 12 plus or minus here or there, like a couple on both ends. But what happens is we have a huge amount of monoclonal gammopathy going on, a large amount of these positively charged proteins sitting in my blood. What ends up happening is it lowers the anion gap. So these patients may have an anion gap of like 4. They may have an anion gap of like 1. Heck, they may even have a negative anion gap, which, right, it can happen. So one thing I do is, right, okay, I see my patient has some of these crab symptoms, right, or they're meeting some of the criteria of the crab. They have an elevated gamma globulin gap. I look at their anion gap, and their anion gap is like 1, right? That tells me there's a huge amount of these proteins that we're like able to like superficially see, right, on the total protein amount and this positive or this very small anion gap, but we don't know exactly what's going on. So this is where that SPEP, UPEP comes into play. So what we do, right, my next step, you're going to see this over and over again. This is the classic step 2 question, is now we have enough information and we say, I want to order an SPEP, UPEP with immunofixation for both. So what we do is the SPEP looks at the serum protein and we place it on an electrophoresis. And what we're going to see is a huge M spike at one area. So electrophoresis, you don't need to know the details of it, but it will just test for how these proteins run down a gel. And if you have a ton of a single type of protein, you can have a huge amount of protein at one part of the gel. And when the pathologist or the lab techs will plot this, they'll have a huge spike at one part on the gel, right? And so that's called a positive M spike, okay? We can do the same thing in the urine, and we do a UPEP, okay? And so the UPEP is just, again, it's testing for the proteins in the urine. And in this case, we're looking for the Bence-Jones proteins, which we already talked about. What you do then is, if we see we have a positive M spike, and again, I don't have a picture on here. I could have put a picture, but I feel like it might just like confuse people. You can just look up online, go on to Google, and just type in M spike gel electrophoresis or M spike electrophoresis, and you'll see just kind of how it's plotted. Because every now and then NBME might decide to get tricky with you and put that on there instead of saying there's a positive M spike. But you'll see that. The thing is, though, that M spike just tells me there's a ton of a monoclonal protein in my body, right? It just tells me there's a ton of them of one single type. It doesn't tell me what type. So that's where the immunofixation comes in, okay? So the immunofixation takes it one step further. We take that M spike protein, they're able to do a little bit more to it, and they're able to figure out, is this IgG, IgM, IgA, because that comes into play. If we see IgG, we lean more towards multiple myeloma. If I see IgM, I lean a little bit more towards Waldenstrom. If I see IgA, right, there's a couple things that could be, and that's beyond the scope of step 1, step 2. We can also do what's called free light chain assay, which is a very sensitive but not specific test. So remember, sensitive versus specific. Sensitive means it should find almost everyone with the disease, but just because you have a positive free light chain assay doesn't mean you actually have the disease we're looking for. The classic example I always give is ANA with lupus. So, right, ANA is like extremely, extremely sensitive for lupus. So that means like 99 to 100% of patients with lupus will be ANA positive. So if I have a patient coming in, they have some of my SOAP Brain MD criteria that they're meeting. And again, I'll do a whole nother talk on lupus. So if you're like, what the heck is SOAP Brain MD? Don't worry about it now. You'll learn about this disease in your MSK units, and it will keep coming up because it impacts every disease. But if I suspect a patient has lupus, one of the first tests we order is an ANA. If the ANA comes back positive, it keeps lupus on my differential, all right? It doesn't mean the patient has lupus. It keeps lupus on the differential. But let's say I order an ANA and it comes back negative. Now I can be pretty certain it's not lupus, okay? So if the ANA comes back positive, I keep lupus on the differential. If it comes back negative, I look elsewhere. After the ANA comes back positive, then we order more specific antibodies like anti-double-stranded DNA and my anti-nucleosome or my anti-Smith antibodies. Okay, so same idea with the free light chain. If they come back positive, we keep my plasma cell dyscrasias on my differential, but we have to do more specific tests. All right. There's this thing called rouleau formation, which again, I don't have a picture of it, but you can easily just look up on Google rouleau formation. The positively charged proteins that are like super high in my body now with this monoclonal gammopathy, they cause abnormalities in the way the red blood cells kind of connect with each other, and they almost form like what's called a stack of coins formation, which is what the rouleau formation will show. So again, just look up online rouleau formation. It'll take you 1 second. I should have put a picture in, my bad. But that is a classic sign. Again, it's not specific, but it's a classic sign that you have some sort of extra positive charge in my body that's causing abnormalities with the way the red blood cells interact with each other, and they form this nice stack of coins. Okay. Again, we see a normocytic anemia. The normocytic anemia may be secondary to anemia of chronic disease. It may be secondary to kidney dysfunction, right? So those are all things we need to consider. And then the other classic thing is we usually won't see any protein on the urine dipstick, even though the patient is losing a ton of immunoglobulins and these Benz-Jones proteins in their urine, right? Remember, we just talked about it. The kappa and lambda form the Benz-Jones proteins and they deposit into the kidney. And the patient has all this protein, right? They're going to end up peeing some of it out, even though the kidney is really good at blocking proteins. If you have so much of it, we're going to overwhelm the kidney. The problem is my urine dipstick, it only picks up albumin on the urine dipstick. It's not going to pick up urine or Benz-Jones proteins or these kappa or lambda light chains. So you can't be like, oh, they don't have any protein on their urine dipstick. I don't think this is multiple myeloma, right? The urine dipstick's not going to pick it up. It only picks up albumin. All right. Let's keep moving. Again, imaging, right? We've already talked about it. We want to look for those punched out lytic lesions, especially in the skull, spine, and pelvis. So we can start with an x-ray, and then if needed, we can progress to more of like the big gun tests, like the MRI and the PET-CT, which are the preferred tests, right? But oftentimes, right, if we're thinking about like just trying to save money for our patient and trying to screen here and there, x-ray is usually the first line, and then more definitive would be the MRI and PET-CT. So again, let's think about our classic presentation. We've now just gone over a ton. Let's kind of put it more together. Older adult, so we're thinking like someone past 60 years old. They've got bone pain in their back, their ribs, maybe even their skull. They've got fatigue, maybe secondary to the hypercalcemia or the anemia. They've got these recurrent infections. Wait, what? Why are they having recurrent infections, right? They have a huge amount of monoclonal antibodies in their system. Shouldn't that protect them against infections? But this is where you really have to think. Remember, we talked about at the beginning, if I have like a strep pneumo infection, we can go through VDJ recombination, somatic hypermutation, and we can make very specific B cells and plasma cells that make monoclonal antibodies directly targeting certain antigens on this strep pneumo, right? And we can attack it from multiple different areas. In multiple myeloma, we are just making the same plasma cell over and over and over and over and over again. So we're making the same antibody over and over and over and over again. And that leaves us very susceptible to infections because instead of mounting a proper immune response, we're just making the same antibody that may or may not have any kind of capability of getting rid of the pathogen, right? We also see the renal dysfunction. So again, we talked about multiple mechanisms. The amyloid, the calcium, and the light chains, the kappa lambda, can all deposit into the tubular system. And then the hypercalcemia, right? And we're going to flesh out why they have hypercalcemia at the end here. All classic. So what are some complications? We've really already talked about a lot of them. Renal failure, we've talked about those mechanisms. I'm not going into that again. Infections, right? Decreased normal Ig production. So remember, my antibodies are really important for the encapsulated bacteria. That's why I brought in strep pneumo. Can you tell me some of the other encapsulated bacteria I'd be worried about? So that's going to be my Shin's pneumonic, right? So the S is strep pneumo, the H is Haemophilus influenza, the N are my Neisseria species, and the other S is Salmonella, all right? We can get spinal cord compression from the plasmacytoma or from fractures, and then the amyloidosis, the AL type, right? It can coexist, right? Amyloid is an acute phase reactant. It can occur after these plasma cell dyscrasias, right? And amyloid can really deposit into any organ system. It can cause liver damage, kidney damage. It can cause restrictive cardiomyopathy, deposit into the tongue. It can cause macroglossia. It can deposit into my carpal tunnel and cause bilateral carpal tunnel disease. All things you want to consider. So what is my differential for when I'm starting to think about plasma cell dyscrasias, right? Everything we've talked about, right? So where it kind of goes into like what is this myeloma? Like the way I think about it is this myeloma or is it something else kind of in the same family, right? So there's what we call MGUS or monoclonal gammopathy of undetermined significance. So that's where the M spike is less than 3 grams, but there is an M spike, but it's less than 3 grams per deciliter. And then there's less than 10% plasma cells if we were to do a bone marrow biopsy, and there's no CRAB symptoms or very minimal CRAB symptoms, okay? So that's called monoclonal gammopathy of undetermined significance. They're making an increased amount of these monoclonal antibodies, but not enough to actually qualify for multiple myeloma. There's been a lot of research, and usually the literature will state that if you have MGUS, your progression to multiple myeloma increases by about 1% every year. So it's something you do need to keep an eye out on, right? It's not just something we say, hey, you have MGUS and we'll see you again in like 20 years when you come back for your next appointment. It's something you do want to keep an eye out on. Then there's something called smoldering multiple myeloma. So this is where we have the M protein greater than 3 or the plasma cells greater than 10%, but they're not having any of that end organ damage yet that we see with the CRAB mnemonic, okay? So now they've qualified for a multiple myeloma type picture based on the M protein and or the plasma cells having over 10%, but they don't have any of the CRAB mnemonic. Again, this can progress to multiple myeloma, so we have to keep an eye out on it. Here's, as I promised, the Waldenstrom macroglobulinemia. So I kind of consider it like the brother of multiple myeloma. Instead of it being IgG mediated, it's IgM mediated, right? So that M spike, right, we'll see, right? Let's say we have a patient, we don't know anything about their symptoms, but I just give you this M spike, right? I give you that M spike and you'd be like, hey, well, this could be smoldering multiple myeloma. This could be Waldenstrom. This could be multiple myeloma. It could be a couple other things too, but you have no way to tell, is this IgG or IgM, to kind of point you in one direction. That's where that immunofixation comes into play. When we do the immunofixation, we're able to tell, is this an IgM M spike or is this an IgG M spike? With IgM, remember IgM can form that pentamer. It's a massive protein, right? It has all these different arms and can form that pentamer, and it will cause what's called hyperviscosity syndrome. So when I think about hyperviscosity syndrome, it's exactly what it sounds like. It makes my blood very viscous. And so what happens is when the blood gets very viscous, your blood pressure goes up. We can get clotting, right? If my blood's really thick and it's like sludge, it's like tar, we can get clotting. So we could have strokes, we could have headaches, we could have blurry vision, we could get numbness and tingling in my fingers and toes. Those are all signs of hyperviscosity syndrome. And in Waldenstrom, we don't really get any of those lytic lesions. There is a test we can do called serum viscosity. So if we suspect Waldenstrom, we can order a serum viscosity and we would expect that to be elevated. And then there's the primary AL amyloidosis. We'll have to use our Congo red stain that will stain things apple green by pharyngeans, right? We might see nephrotic syndrome due to deposition of my amyloid into the kidneys itself, leading to damage of my glomerular basement membrane, leading to leakage of protein into the tubular system and out into the urine. And again, we could see restrictive cardiomyopathy where the amyloid deposits into the heart. It makes my heart not able to expand and accept volume. So the diastolic amount that the heart is able to accept is very, very minimal. All right. More to come in your cardio unit if you haven't had cardio yet. So treatment is overall very low yield for it's 0 yield for step 1. You don't need to know really treatment. Very low yield for step 2. But really, if the patient is transplant eligible, we'll do induction with bortezomib, which is a like a protease, like a ubiquitin protease inhibitor. We can use lenalidomide and then dexamethasone, so a steroid, and then we can progress to autologous stem cell transplant. If they're not eligible, we can use the same regimen without transplant, and then we can do supportive care. Bisphosphonates are going to cause osteoclast apoptosis, which will decrease some of the hypercalcemia symptoms and some of their bone pain. We'll use hydration for hypercalcemia. So a classic step 2 question, you have a patient come in with confusion, constipation, increased urination, dry mouth, and you see their calcium is like 14. The first thing you're going to do is you're going to give them IV 0.9% normal saline before we do anything else, right? That's going to help protect the kidneys. It's going to help wash out some of that hypercalcemia. We're going to avoid nephrotoxins, and then we can do VZV prophylaxis, right? If they're using bortezomib, that can predispose you to VZV or reactivation of VZV. So we can use prophylaxis there. We'd have to use like acyclovir or valacyclovir for that. If they get infections with multiple myeloma, we can use IVIG, especially if they have recurrent infections. And then there's emerging therapies like CAR T, anti-CD38s, and then bispecific T cell engagers. Again, all very low yield for step 1 and step 2, but I wanted to put it in for completeness. So again, how do I think about multiple myeloma, right? It's really important to get your clinical frameworks in play. I look for an older adult, right? Right off the bat, if my patient is a 20-year-old female with some of these signs and symptoms, there's a very low likelihood that it's actually multiple myeloma or plasma cell dyscrasia. Obviously, we can't disclude it, right? We have to consider it, but again, it's usually an older adult with the fatigue, bone pain, or kidney injury. We look for the elevated total protein and that gamma globulin gap. They might have a low or negative anion gap. We'll look for their crab or their slim features. And then if they meet some of those, right, that's when I would consider ordering SPEP, UPEP, free light chains with immunofixation, right? If those come back with a positive M spike, now we can confirm with the bone marrow biopsy. If they have over 10% plasma cells with positive IgG, right, we're thinking multiple myeloma. If it's IgM, we can think about Waldenstrom. And then we can stage and risk stratify with cytogenetics to determine which type of treatment and monitoring we need. All right. So your pearls for the board, just kind of reiterating what we've talked about. There's not going to be any protein on the dipstick plus elevated protein, right? So you're looking at their CMP and you're like, there's elevated protein. They have a kidney injury, but there's no protein on the dipstick, right? That's again because the Bence-Jones proteins won't show up on the dipstick, only albumin does. If we think about bone lesions and a normal alkaline phosphatase, that we think about lytic, not blastic, right? So that's multiple myeloma. Whenever I see an elevated alk phosphatase with a negative or normal GGT, I usually think more about a bone turnover, right? So alkaline phosphatase is made in the liver, it's made in the bile ducts, and it's made in the bone, right? So if you haven't had your GI unit yet, this probably won't make sense to you. But if your alk phosphatase is high, I want to also get a GGT level because GGT is very specific or is more specific to the bile ducts. So if I see that ALP is elevated, then I want to get a GGT. If the GGT is normal, that tells me that ALP is likely coming from some sort of bone turnover. And usually that's an osteoblastic or osteosclerotic lesions, right? In multiple myeloma, they're osteolytic lesions. The osteoclasts are actually chewing up the bone itself. It's not bone turnover. We're chewing up the bone. So ALP usually isn't elevated. Sometimes it can be. Whenever we see hypercalcemia plus an AKI plus anemia plus a back pain, consider multiple myeloma. Remember, MGUS, I told you its progression risk to multiple myeloma is about 1% a year. And then Waldenstrom is IgM, whereas multiple myeloma can be IgG or IgA. All right. And again, if you haven't done GI yet and that ALP thing really confused you, don't worry about it. Again, really in brief, ALP is kind of less specific to the bile ducts. ALP can be made in the bile ducts. It can be made in the bone. It can be made in the placenta. It can be made in a couple other places. So if I see an elevated ALP, I need to be thinking about biliary pathology. I need to be thinking about bone pathology. So one thing I do is I order what's called a gamma glutamyl transferase or GGT. GGT is a very specific protein made in the bile duct epithelium. And so if we have bile duct damage, that GGT goes sky high. And so if I see the GGT and ALP are both elevated, I'm pretty certain it's more of a biliary problem. But if the ALP is elevated and the GGT is normal, then we can say, okay, maybe that ALP is coming from the bone and not the bile duct itself. And ALP usually only gets made or it gets released when we have some sort of osteoblastic or osteosclerotic problem. Whereas in multiple myeloma, it's osteolytic. So usually not as high amount of ALP being released. So if you want to read more, here's Diagnosis and Management of Multiple Myeloma. It's a great JAMA review article from 2022. So you can screenshot that, put that into Google. So let's put it all together. So I've alluded at this, right? How does the mechanism of hypercalcemia in multiple myeloma differ from the mechanism of hypercalcemia in sarcoidosis, tuberculosis, Hodgkin's lymphoma, and squamous cell carcinoma of the lung? I cannot stress this enough. This is such a high yield concept for step 1. And honestly, even for step 2, I promise you for step 1 at least, they will ask you about the mechanism of hypercalcemia for at least one of these diseases. For step 2, they may ask you the pathophys again, or they may ask you treatment. And remember, treatment is going to be that IV 0.9% normal saline. We can add calcitonin. That'll work now. Bisphosphonates are more of the definitive management. I'll do a lecture on hypercalcemia and go more into depth later. But for now, tell me the mechanisms of these causes of hypercalcemia. So pause your screen. All right. So in multiple myeloma, we've kind of hinted at it, right? But it's osteolytic bone destruction due to cytokine release. So in multiple myeloma, we increase the amount of IL-1 and some of my other cytokines. And those IL-1 is specifically called osteoclast activating factor. It does exactly that, right? So all these plasma cells are increasing the amount of IL-1. We overactivate my osteoclast and my osteoclast chew up bone. So we get local osteolysis. Again, the increased calcium feeds back, it shuts down parathyroid hormone production. So PTH is low. This often presents with bone pain, lytic lesions. There's no PTH-RP or vitamin D involvement. Sarcoidosis. So sarcoidosis, we make non-caseating granulomas, right? Classically in the lungs, sometimes in the liver. We can get deposition into the heart. We can really, it's one of those crazy systemic rheumatological diseases that are super interesting, right? Because it can impact everything. But whenever we get granulomatous formation, we are overactivating these epithelioid histiocytes, which have a lot of 1-alpha hydroxylase in them. So what happens is those epithelioid histiocytes or macrophages upregulate the production of 1-alpha hydroxylase, which increases the conversion of 25-OHD to 125-OHD, which then goes to the gut and increases the amount of calcium we reabsorb. So the key mediator here is the 125-OHD. Again, we're going to see a low amount of PTH because this is not a PTH-driven mechanism. So again, it's going to be the same mechanism as TB, but for sarcoid, they're non-caseating granulomas. For TB, they're caseating granulomas. So again, we don't really need to talk about it for TB. We just talked about it. Sarcoid, non-caseating granulomas increase the production of 1-alpha hydroxylase. TB, caseating granulomas increase the production of 1-alpha hydroxylase. We increase 25 or 125-OHD, goes to the gut, increases calcium reabsorption. Hodgkin's lymphoma, hey, guess what? Same idea, right? So we secrete 1-alpha hydroxylase from the tumor or the granulomatous components. We increase calcitriol, the activated vitamin D, we increase the gut reabsorption, all right? So really like sarcoid, TB, and Hodgkin's lymphoma, very similar. I will tell you things like Crohn's, borreliosis, histoplasmosa, and GPA all have a very similar mechanism too that involve granulomatous formation and then increase 1-alpha hydroxylase. So all things to consider. And then our last one, squamous cell carcinoma of the lung. So squamous cell carcinoma of the lung is usually a central tumor in the lung that's usually found in older male smokers. And this tumor itself can secrete what's called PTH-RP or PTH-related peptide. This guy mimics exactly PTH. So it does everything. Go back to the beginning of my video where I talked about PTH. It does everything PTH does, except it doesn't really activate 1-alpha hydroxylase as much. But you don't really need to understand that. All you need to understand is, hey, PTH-RP is going to work a lot like PTH, and it's going to lead to an increased amount of calcium. Now, the trick here, though, is PTH-RP will not be picked up as PTH on a lab assay. So this patient has elevated calcium. You're going to get a PTH level on them, and their PTH is going to be low, right? You have to order a PTH-RP. They work very similarly, but they'll be picked up as two different things on lab assays. So if you suspect the patient has elevated PTH-RP, you have to order a PTHRP. Getting a PTH is not going to give you your answer. And in fact, the PTH is going to be low because this patient has elevated calcium that's going to feed back and shut down endogenous PTH. It's really the PTHRP being secreted from the squamous cell cancer itself that is causing the increased amount of calcium. All right, that was a ton on multiple myeloma. 45 minutes, one of the highest yield like topics for the rest of your life for any board exam you're taking. You will see patients in the hospital who fit a lot of these CRAB criteria, and you have to understand what is my next step in working them up. If it comes back positive, what do I do next, right? Usually the right answer in real life is you talk to your hematologist, oncologist, and they'll usually take over the workup. But for board exams, you can't do that, right? So you have to know the workup. Multiple myeloma, very important. Waldenstrom, MGUS, smoldering myeloma, very important. Please understand the pathophys of everything we talked about. Understanding just like the clinical presentation is not enough. You need to understand the pathophys. Until next time, this will be in the hemonc section, so enjoy. All right.